Hello everyone. The topic of my presentation is use of smartphone microscope in eye clinics. I have no financial interest in the subject matter. With the universal availability of smartphone in the recent years, it has found innovative uses in ophthalmology, including photography as a tool for patient assessment and education, for physician education and reference, calculator tools, teleophthalmology, medical records, and as a tool for branding and marketing. Microscopy, on the other hand, is an extensive field that involves observing minute objects or structures with microscope which cannot be otherwise seen by the naked eye. It is a very important and indispensable tool in ophthalmology. The common routine use of microscope includes slit lamp by microscope in eye clinics and surgical microscope in the operating rooms. The other type of microscope is a histopathology microscope, which you need laboratory access, which may not always be available, especially in the resource limited settings. So we evaluated the utility of a commercially available smartphone device, Nurugo Micro, as an adjunctive tool in the eye clinics. This Nurugo Micro is a small device which can be clipped onto the smartphone to act as a histopathology microscope. Basically, it utilizes the flashlight of the smartphone for illumination and the camera for visualization and capturing the microscopic images with the help of an app which has to be installed onto the smartphone. This is what it looks like on the back view and on the profile view. So we were able to establish its diagnostic value in 3 clinical situations which would otherwise need a histopathology microscope or laboratory services. The first is Demodex blepharitis, which is infestation of eyelashes by mites of genus Demodex, and it is characterized classically by deposits at the base of eyelashes known as cylindrical dandruff. And to make this diagnosis, the eyelashes are epilated with forceps and placed on the glass slide and covered with a cover slip and examined under the microscope. So we were able to demonstrate the presence of these mites with the pocket microscope, although the details were not as clear as a routine lab microscope. And however, we found, as has been previously described by Hyphae et al., that addition of a drop of fluorescein dye to the saline results in contrast enhancement and better visualization and capturing of the images of these mites. The second use of pocket microscope was detection of fungal hyphae in 10% KOH solution of corneal scraping in cases of fungal corneal ulcer. Although we were initially not successful in imaging the hyphae, likely due to lack of contrast to pick up the hyaline fungal filaments on 10% KOH stain, we found that addition of a drop of Trypan blue dye, which is routinely used for capsular staining in cataract surgery, stains these hyphae blue, and then it allows for easy visualization and photography. This is a demonstration of novel use of Trypan blue dye to stain fungal hyphae, as has been captured through a regular lab microscope. After staining with Trypan blue, these filaments can be easily picked up by the smartphone microscope attachment, and the slides can be scanned and areas of interest can be focused and images can be captured. So this is a comparison between lab microscope and with the pocket microscope, although the details are not as clear as the lab microscope, but still it's sufficient to make a diagnosis. The another use we found of this pocket microscope was examination of the histopathology slides. Quite often, ophthalmologists would like to see and review the slides of surgical specimen, especially generated by themselves, and it may not always be possible for ophthalmologists to visit path lab for various reasons for review of these slides. We found that this pocket microscope is useful in capturing the details of histopathology slides, as has been shown in this representative diagram of spheroidal degeneration of cornea, and the mauve color deposits are very well demonstrated in comparison to the traditional lab microscope. With a little bit of learning curve, one can learn to scan through the various parts of the slide and focus on the areas of interest to capture images or make videos which can subsequently be shared. The use of smartphone enabled pocket magnifier has been earlier reported by Agarwal et al., who used a different battery enabled device to demonstrate hyphae in the fungal keratitis cases, and they used lactophenol cotton blue stain to improve visualization. We did not have access or expertise for this stain in our clinic, so we used Trypan blue dye, which is universally available in eye hospitals, and with this stain we were able to detect and capture reasonably good pictures of the stained hyphae. We also report the novel use of pocket microscope to detect Demodex mites in dilated eyelashes, and this would be useful to make diagnosis of this entity in situations where histopathology microscope is not available. To conclude, we report application of smartphone-based imaging in 3 clinical entities, which may be of great significance in routine ophthalmic practices, especially in resource-limited settings, and further studies may help in establishing the accuracy and cost-effectiveness of these innovative systems in ophthalmology. I would like to acknowledge my co-authors. Thank you for your attention.